And I'd like to introduce our speakers today. We have Jennifer, who's a PhD candidate at the University of Hong Kong. We have Xiaofan, who is also a PhD candidate in medical anthropology from the University of Hong Kong. We also have Minsu, who is also a PhD candidate at the New School. So without further ado, I'll let them do their thing.
I don't know the mic. No, you want to use it. Okay. Well, where's the clicker?
I'll get you a clicker.
Hi, everybody. I'm waiting for the clicker, but I'll just introduce myself. My name is Jennifer Doherty. I am in the Medical Ethics and Humanities Unit at the University of Hong Kong. And I have two supervisors. The first one is Alex Guerin. He's an anthropologist. And the second one is Peter Tanus-Putro, and he's a primary care doctor and palliative care specialist. I am researching psilocybin therapy for end-of-life distress in Hong Kong. I'm not disclosing, I have no disclosures for my research. So I have three research questions, and they are as follows. What are the theoretical pathways to clinical research in Hong Kong? What are the barriers to acceptability for psilocybin therapy in Hong Kong? And what are the cultural sensitivities that we should consider? So that I don't have to look back. In a nutshell, Hong Kong is a special administrative region in China. There are 7.5 million people there. 92% of them are ethnic Han Chinese. There is a large disparity in wealth there. We also have some of the longest living population, and we're very proud of that in Hong Kong. And also there's public and private healthcare systems. Here, I'm giving you a little bit of a background of what we're dealing with in Hong Kong. It's zero tolerance there. As you can see, these are some of the public health posters, and you can find them in undergrounds. You can also find them at music festivals, wherever the youth might be. And I'm also showing you a little bit about the literacy of drugs there, because CBD is a banned substance since 2023. It is considered a dangerous drug. So working or even talking about psilocybin in Hong Kong is quite challenging, as you can imagine. Thank you. So these are the three potential clinical pathways to researching psilocybin. I'm not going to go into the first two because they're pretty self-explanatory, and they are as other jurisdictions. So the clinical trial pathway, in which a sponsor investigator would need to sponsor the trial. The second one is the compassionate use special access named patient. The third one is quite interesting. It's called the +1 mechanism, and this was started in 2021, if I remember correctly. And what it does is it fast tracks drug approvals, because Hong Kong is not a place for primary drug approval. It depends on countries, other countries, to approve of a product, and then it can fast track it. But they do require local clinical data. And if we don't have local clinical data, then at least we should provide some data with the Han Chinese ethnicity, which is currently missing in most clinical trials with psilocybin. So this is the rationale for the research. I'm looking at demoralization, so the loss of meaning and hope with people that are diagnosed with a serious illness. There seems to be quite a high prevalence of demoralization in Hong Kong. 10% of those who died by suicide had a history of cancer in Hong Kong from 2003 to 2017. And by 2050, most suicides will be related to physical illness, and that's attributed to an aging population. So it is something for me that's quite important to look into. This is my methodology. It is a work in progress. I've interviewed 10 clinicians so far. My aim is to interview 16 or reach saturation. I'm doing semi-structured interviews with clinicians such as doctors, psychiatrists, psychologists, nurses, and they must be working with patients with serious or terminal illness. And I'm using the theoretical framework of acceptability for my study. Today, I'm only going to be sharing 3 frameworks due to time constraints. They are affective attitude, burden, and acceptability. So the first question that I'm sharing is, how comfortable do you feel about engaging with or providing psilocybin therapy if it were permitted? The 3 clinicians that were comfortable with this are all in supportive roles, so they have no prescribing powers. 7 respondents were either unsure or they were not uncomfortable. 6 clinicians with prescribing powers would refer the patient with existential distress or demoralization to other departments and specialties. So what I've done is I've mapped out what the clinicians have said to me in terms of who they would refer the patient to. So as you can see, there's a lot of referrals to geriatrician and palliative care, but palliative care would refer to a psychiatrist. So this is a work in progress, but I'd like to ultimately find out where this potential therapy or intervention would sit. If it were available, how much effort do you think it'll take to offer psilocybin in your work setting? Respondents mentioned either a lack of space, staffing, or cost being prohibitive. And this is something that I think we see across all healthcare systems, especially with this therapy, considering how long it takes, and it's very human resource intensive. 2 suggested that family members look after the patients, and those who could make it work had private spaces. So they either had a private room in the ICU, private room in old age homes, or a private room in their clinic. Then I asked, overall, how acceptable is psilocybin therapy to you? And it was very encouraging to see that there is acceptance for this therapy with caveats. The caveats being that there needs to be enough evidence, it needs to be legal, there needs to be a team that is available to carry out this intervention. And one doctor said that they're willing to work with it in a research setting, but not in routine clinical settings just yet. The psychiatrist that I interviewed, he didn't answer yes or no, but considering the entire talk, he was more conservative, as he said himself. So this was a really kind of big finding for me, is that 8 out of the 10 respondents mentioned that they would need the family approval consensus involvement for psilocybin therapy given to the patient. And I wanted to read out what this person said. It is going to be difficult to reach a consensus over the patient's treatment and end-of-life care, especially concerning an experimental or novel therapy. Probably the practitioner has to put in a great deal of effort in explaining to different people within the family, getting buy-in, and allowing them to express their own concerns and addressing them one by one. We might be seeing some difficulty with our elderly patients because they often give up their rights of decision-making and delegate to the younger family members. Use of psilocybin is something very personal. I doubt this kind of surrogate decision-making or this kind of so-called relational autonomy would play well in the consenting process. So as you can see, this is a potential big barrier to the implementation of this intervention. I'm sharing with you some of the references that I used in my slides if you want to read up further. So in doing this research, I have many more discussion points, and they are, where would this intervention take place in a public healthcare setting, oncology, palliative care, or psychiatry? What are the ethical and clinical implications of family members supporting patients? How can we overcome the economic barriers to psilocybin therapy and provide equitable access? So if you do see me and have some of answers or advice, please flag me down. I'm here and I'm so grateful to be here, so thank you very much. I'm also looking to connect with clinicians and jurisdictions that can provide real-world evidence, drug companies that may be interested in conducting a clinical trial in Hong Kong, and historians of hallucinogenic substances in Asia, and finally, anyone working in this particular space. Thank you very much. I'm passing over to my colleague, Xiaofan.
Thank you, Jennifer. Good afternoon, everyone. My name is Xiaofan, and I'm a PhD candidate at the University of Hong Kong. And I will share my ethnographic research, which examines esketamine treatments as an example of non-classic psychedelic, specifically the role of families in the esketamine treatments in China. So, a brief clinical context. Esketamine is a dissociative anesthetic, and the medical company Johnson & Johnson's Spravato medication is being increasingly adopted across the globe for depression, demoralization, and other psychiatric conditions, and including in the Chinese context, which I will discuss today. So in China, esketamine is classified as the first-class psychotropic drugs, which is among the most strictly controlled substance. So in this context, Spravato is also strictly restricted to the psychiatric departments in the general, mostly public hospitals. And as trained in medical anthropology, I do ethnographic fieldwork in the hospital in Guangzhou, China. And I attend outpatient visits and also esketamine dosing sessions to do observation and interviews. And this image on the left was me wearing a white coat in a psychiatric hospital in Guangzhou. And the right image shows the daily environment of the Spravato sessions in the outpatient or the emergency wards. And now this AI-generated image captures a scenery that I observed very frequently. So a patient is lying down on the bed after receiving Spravato with their eyes drifting. And their family member sometimes sit at the bedside and offering physical support, such as giving their hands, well, often just being present. And this scenery brings me to my central question of my talk today. What role does family play in esketamine treatments in Chinese context? And also, what can this tell us about the family-embedded psychedelic treatment more broadly? So, many people are aware of the concept of set setting today in the psychedelic humanities research. And this is where patients' expectation, belief, and mood, along with the social and physical environment, shape the experiences in various ways. And in later times, concepts such as the matrix or collective set and setting incorporates the everyday living space and the social cultural background. But still, in the psychedelic literature, the family is often not involved in the treatment or is simply treated as the psychosocial background, and mostly as part of the preparation or the post-treatment integration, but not as part of the drug treatment session itself. But today, I will explore a different scenario. So in my field work in the Chinese psychiatric hospitals, the family is not the background, but sometimes constitutes an on-site configuration of the setting. So first, they show their presence during the dosing session. They sit at the bedside, not just before or after, but during the session. And second, Spravato is not covered by the medical insurance, and it's very expensive for most Chinese patients, and that makes family as the primary source of financial support. Also, the family members may decide the treatment plan, dosages, and other life decisions together, such as adjusting a school plan or even quitting a job. This treatment process reshapes the family relationships, sometimes opening the conversations that were impossible before. And also, most importantly, the family's members participate in the meaning-making process. According to some scholars in the cultural psychiatry, such as Huang Xuanying and Yang Jie, such redistribution of therapeutic labor absorbed by the families aligns with the shifting role of family in psychiatric care in modern Chinese history. For example, in the Maoist period in the 1950s to the 1970s, the hospital-based care is given way to the community-based care. And it was not until the market reform era since the 1980s, the family itself became a basic unit for economic growth, and it naturally takes more burden of psychiatric care. And from the 2010s onward, after the mental health law is released, the family's responsibility has increasingly centered on caregiving and risk management, including monitoring, ensuring compliance, hospitalization, and preventing relapse. While also on a cultural level, the filial piety of serving the sick creates a moral duty for the family care in China. And adding on to that, as Ma Zhiying, an anthropologist, notes, Chinese family acts as an extension of the paternal state, with a Confucian tradition of state-family isomorphism that positions family care as a regime of paternal management. So, the family is an ideological construct shaped by the institutional history and also the cultural economic factors, making it the default responsible actor in the mental health care. And in the esketamine treatments particularly, the uncertainties of drug experiences, efficacy, and also multi-ontologies, and also the ambiguous narratives of esketamine as being between an illegal drug and a medicine make the role of family care even more prominent and flexible. So two very simple cases from my ethnographic work. Tam is a middle-aged woman who, and she described her hallucinate visuals as floating among the matcha cakes. She said, "I felt so relaxed that life and death don't matter. Among the cakes, there's only the present moment, no past or future." And Tam's daughter has interpreted her mom's esketamine experiences as she's always too perfectionist and anxious about things in the future or in the past, and this helps her to stay in the present moment. So Tam's daughter actually took a long leave from her job in New York and returned to Guangzhou to accompany Tam's every treatment session and join her in the outdoor activities. The daughter explained that caring for her mother is her filial duty, and she worries about her when they're separated by a very long distance. Another patient, Dong Dong, came to her session with her husband, and after 3 doses, she became very expressive, holding her husband's hands. But at one point, she suddenly brought up a very deeply buried memory, the loss of their dog, which had died after her husband fed it with the wrong food. But there was no blame in her tone, only some sadness about something that had been too difficult to discuss in the ordinary life. And her husband also offered a quiet apology and comforted her. In the following sessions, he also actively engaged in dialogue with her, and they even gave names to different personas that Dong Dong experienced during the esketamine treatments, such as the original self, the little left, and the little right. So in both 2 cases, such family-embedded treatment has some element, or at least some attempt, of being psychotherapeutic without a therapist on site. By being physically present, real-time dialoguing and recording, and make meanings of the past traumas and family stories, these family members' role extends to be a co-participant in the therapeutic practices. So let me wrap up and conclude here. The family serves as a critical setting that may shape the efficacy in psychedelic treatments, particularly in the context of the general hospital psychiatry. And in the clinical sessions that I observed, the family is more than just a psychosocial background of set and setting. It becomes part of the on-site infrastructure of the setting. And the family acts as a quasi-therapist, but using not just the biomedical or neuroscientific language, but incorporating multiple ontologies and worldviews, such as the cultural traditions of filial piety, the family stories, and some folk beliefs, religious and ancestral cosmologies. And lastly, let me acknowledge some challenges here. So first, at the individual level, deepening the family involvement can intensify the existing conflicts or trigger traumatic experiences, as returning the patients to the same matrix in which the symptoms developed. So it's a need to identify the trauma-related abuse and to ensure the emotional safety between the patients and the caregivers. And also at the clinical level, when untrained family members might have psychotherapeutic interpretations, questions of safety, professional boundaries, and efficacy become prominent. And recent works by Edward Jacobs and Sarah Forsberg on incorporating family support in PAT on adolescent indicate the importance of psychoeducation and pre-screening of the family dynamics. And also at the social level, this model emerges within a global neoliberal medical market where care labor is systematically devalued and being invisible, which means we'll also talk about in her discussion on the social and geopolitical aspect. So yeah, thank you. This is my sharing today, and I hope it points to some areas of future studies as well. Yeah, thank you.
Good afternoon, everyone. And thank you for the organizing team of ICPR, and thank you, Ray, for introducing us to save us a little bit of time. To respect our time constraints today, I'd like to begin with a brief overview of the ongoing fieldwork in Taiwan that grounds this presentation. For the past 18 months, I have been immersed in the sedimented realities of various adjacent fields within Taiwanese psychedelic research. This landscape spans clinical trials, esketamine therapy, which is currently the only legal form of psychedelic-assisted therapy here, psychedelic retreats, and frontline harm reduction. It is a space where diverse stakeholders, including chemists, architects, psychiatrists, psychotherapists, patients, nurses, lawyers, space holders, and ethnographers like myself actively shape this emerging knowledge community. My question I'd like to raise here is, when and how did psychedelics first emerge as a legitimate or potentially legitimate discourse within Taiwanese psychiatry? This question carries a particular urgency because one cannot speak of therapy without confronting its bio and geopolitical conditions. Sociologist Joanna Kempner, who will be speaking tomorrow as well, has sharply criticized the psychedelic research community for its reluctance to reckon with the contradictions and forms of suffering that entangled early researchers with underground networks, realities they often struggle to acknowledge openly. Throughout psychiatric history, categories of mental disorder were shaped less by clinical observation than by authoritative administrative governance. Therefore, examining how medicalized psychedelic therapy gained institutional legitimacy is simultaneously an inquiry into our present political landscape. I approach this inquiry through three distinct lenses. First, a discursive lens, examining how rumors, conversations, and circulating forms of speech left traces within specific material and social spaces. Second, an institutional lens, attending to the top-down decisions through which geopolitical shifts were incorporated into systems of community regulation. And third, an intersectional lens, tracing the forms of tribalism, exclusion, and affiliation that exceed and at times undermine the frameworks of institutional dignity they claim to uphold. Similar to art history and media studies approaches that trace shifts in representation, I mapped how translations of psychedelic substances evolved within Taiwan's digital public sphere over recent decades. In doing so, three recurring linguistic patterns emerge. 迷幻药, a term closely aligned with the literal translation of hallucinogen, foregrounding illusion, cognitive distortion, and deviance. 放心药, fluidly translated as mind-releasing or mind-liberating medicine. This term appeared frequently in media discourse from the 1990s into the 2000s when the Western culture, pop culture, started to take in the mainstream, and publicly articulated by translator and queer activist Josephine Ho through her countercultural writings and media interventions. And 吉林药. Beginning in the 2010s, this term began to circulate rapidly. Characterized by meanings of opening, awakening, or enlightening the spirit, it represents a profound discursive shift away from the language of pathology and toward frameworks of spirituality, transformation, and therapeutic potential, as seen in the Chinese translation of Michael Pollan's How to Change Your Mind, which you can see in the right top side. Within this subtle yet distinct shift in terminology, words that circulate through the social sphere as symbols, indicators, and mediators of this therapeutic object, we glimpse the layered historical realities each term carries. Embedded within them are traces of the Opium Wars, the collective aftermath of martial law, and a political aspiration to locate common ground and amid ongoing crisis surrounding identity, legitimacy, and the promises of scientific transparency. From an institutional approach, these crises expose what historian Harry E. Ju Wu describes as an incomplete decolonization of post-war psychiatry since 1945, through which conflicting communities of thought migrate and evolve. In contemporary Taiwan, the emergence of psychedelics as a deliberate care modality, grounded in neurobiological, theological, and phenomenological frameworks, acts as a critical lens through which these layered post-colonial genealogies unfold across multiple scales. Tracing this genealogy backward reveals how modern frameworks remain anchored in the past. Large-scale township surveys conducted by local authorities, medical practitioners, and police directly inherited the logic of colonial racial hygiene studies. Through these early epidemiological investigations in the 1950s, these projects laid the structural groundwork for Taiwan's mental health infrastructure. Published in English, their findings gained international recognition and later informed the WHO's research in social psychiatry. Subsequent clinical trials, survey designs, and community services likewise followed international standards while adapting to shifting political realities. Operating under Kuomintang authoritarian rule and Cold War geopolitics until the 1990s, Taiwanese psychiatrists, often native-born yet colonially educated, drew simultaneously from the intellectual traditions of Imperial Japan, Fascist Germany, and the Western Bloc, as noted by STS scholar Wenji Wang. Consequently, complex questions of race and ethnicity were reformulated into state-sanctioned languages of culture, social adaptation, and developmental stages. Ultimately, as Taiwan democratized amid global neoliberal health reforms and data-driven psychiatry from the 1990s and onward, this institutional focus on social adaptation shifted. It gave way to localized therapeutic communities where trauma, now framed as a vital component of transitional justice, is understood to carry profound long-term psychological ramifications that contemporary interventions, affiliations, and exclusions continue to inherit and contest. This leads directly to the third analytic layer, the intersectional dynamics of race, class, and gender that complicate the integration of psychedelic therapy. Within underground networks and informal apprenticeships, deeply entrenched power dynamics frequently manifest as subtle abuses rationalized by appeals to interspirituality. This dynamic is starkly evident in terms like Formosa Huasca and Asian ayahuasca, labels that enact a double exoticization, mapping Western spiritual tourism onto Taiwan's native psychopharmacology and ceremonial landscapes. Concurrently, local botanical, medical, and religious experts convene out of a distinct blend of intellectual and spiritual aspiration, a duality captured by the term Qilin Yao, as they negotiate how to integrate these substances into contemporary care. Notably, my interviews with field participants reveal a sharp disparity between scientific discourses, which neatly categorize phenomena like mystical experience or ego dissolution, and actual lived realities. What even is the ego, one might ask? While the concept relies heavily on psychoanalytic assumptions, real-world settings are routinely disrupted by interpersonal friction. In practice, certain individuals project their own certainty about altered states onto others, forcing vulnerable participants to navigate their own certainty, navigate their discomfort of unwanted intimacy at the hands of a self-proclaimed expert. These messy relational dynamics consistently slip through the cracks of a scientific rigor that routinely dismisses negative experiences as mere statistical noise or experimental error. Synthesizing these three perspectives reveals a critical tendency that demands our attention as the adaptation of psychedelic therapy unfolds in Taiwan. Recently, we have witnessed a growing body of clinical studies attempting to apply psychedelic treatments to complex PTSD, a concept Judith Herman introduced at length in her landmark 1992 work. Yet, when dealing with systematic, historical, and intergenerational wounds, a haunting question remains unanswered. Where exactly is the post in chronic trauma? This brings me to my concluding remarks, which draw upon the insights of historian Achille Mbembe. Mbembe aptly captures the profound political and ethical stakes of the neoliberal wave currently sweeping through scientific and psychiatric discourse, writing, "These are not merely political in the sense that the triumph of neoliberalism might herald the powerful return of tyrannical or even fascist potentials in societies that were hitherto deemed so-called open societies. Nor are they only economic, in the sense that financial capitalism now tends to merge with algorithmic reasoning, and economics itself fuses with the biological and neurological sciences. When psychedelic therapy fuses so neatly with algorithmic and neurobiological frameworks, we risk flattening the very historical realities and post-colonial frictions we have discussed today. If we ignore these scales of situatedness, we merely innovate new ways to enforce social adaptation rather than achieving a true shift in the paradigm. The reference for today's talk are displayed here on the slide. If you would like a copy of the presentation slides or wish to extend this conversation, please feel free to reach out to me at the email address listed above. Thank you all very much for your time and attention. We will now begin our Q&A session.
So yeah, time for questions. If anyone wants to ask a question, raise your hand up.
Thank you all for your work. I wanted to ask if there was, in the esketamine-related themes of I think the last two at least, of your presentations, is there any racemic ketamine off-label alternative to esketamine in these spaces? And if so, is psychedelic-assisted therapy perspectives being utilized with that? Because I don't know and I would love to hear.
sorry, can you repeat the last sentence real quick?
Very shortly, is there an alternative to the esketamine with racemic off-label ketamine for accessibility reasons and financial cost and all of that? And also, is psychedelic-assisted therapy models being utilized together with the esketamine or the ketamine?
Yeah, so nowadays there are both the supravital treatment and also they're doing the IV pump, and it's actually more accessible and financially it's cheaper because it's within the clinical research tools. So many of the Chinese patients, when they reach the indications for the such as treatment-resistant depression and also with the suicidal ideations, so they might get the go into the clinical research trial, and that made it more much more cheaper and accessible. Yeah. No. There's no a psychotherapist in my research in China, but I'm doing a multi-field research in Taiwan and Hong Kong, and also Minsu is doing a research in a clinic in Taiwan, and they're doing the PAT. So the psychiatrist is actually there, and he's using the Spravato combined with the psychotherapies.
Any other questions?
This is for Jennifer. I've been a chaplain at UCSF for 10 years, so the Asian population is near and dear to my heart. I also lived in Asia in my 20s, so I really made it a point to use my time there to tend to these patients. And everything you've said was my experience, that often when I worked in palliative care, and often when I needed to work with Asian families, I needed to work with the family, like 20 family members in the room in the middle of the night. And the patient's in the bed dying, and they're not telling the patient that they're dying, right? So I don't know what my question is other than to say, I have so many ideas, but how to enroll the family in this concept that the family can address these issues together, because it's so clear that you need to work with the family. And so I don't know if there's a question here about anything. It's just like so many thoughts are coming to my mind, and so many nights of being on call and tending to this population with care. Yeah.
Thank you very much for sharing. And I guess I see family being very important, being in Hong Kong and doing the research, and to hear that it happens elsewhere with the diaspora of Chinese people, it does reinforce how important it is to address the family. I don't know how that will be done yet, considering there's very low knowledge of psilocybin therapy. So imagine you have to educate, from the ground up. And I'm hoping that maybe we can frame it in an ethical way of, providing your loved one with a good death, or, there's some comfort there. But I don't know what that is yet. Yeah, thank you for sharing.
Do you want to? Okay.
Hi, I'm Sophia. I'm Chinese from mainland China and studied in New York City, and then also CIIS. I'm a music therapist and also psychedelic assisted therapist in California. So I wonder how much we can talk about in public in Hong Kong, Taiwan, and mainland China. Like public education, can you host event to do education, talk about it? I know there's no way like legally to do the work, and maybe one or two like clinical trials. So I wonder, yeah.
I'll answer and then I'll pass to you girls if you want to say anything. We haven't talked about it publicly yet, but the fact that they allowed me to do research at the University of Hong Kong, I think is a pretty big step already. But I think what needs to happen is eventually, hopefully, a journal article in the Hong Kong Medical Journal, let's say, to talk about it. Because even all the clinicians that I interviewed, I had to give them an information sheet because the majority of them did not know what psilocybin therapy was. They didn't know this existed, or that this, mushrooms, hallucinogenic mushrooms, really existed for therapeutic use. So, yeah, it's going to take, I think, quite some time, and it's baby steps. Yeah, baby steps at the moment.
Yeah, thanks for your question. I think the media post outside the academia is very important, especially on the social media. So I can see emerging media accounts posting their medical knowledge about esketamine treatments at least, and also some clinical trial progress such as psilocybin outside the Asian context. So I can see these discussions and tensions in the comments, but I think it's a great way to reach the public as well. For example, I read a very interesting article about esketamine. They would say from K powder to a medicine for depression. So K powder is exactly the term to describe ketamine. So in a very stigmatized way. So yeah.
Sorry, I think we do have to end. We have a next session, and you can continue the conversation later. Thank you.